Hi, I'm Dr. Sajita. I'm an obstetrics and gynaecology doctor here at UMBI. Today we're talking about induction of labour, and there are lots of reasons why this might be recommended to you. It could be to do with the growth of your baby, either being too big or too small. You could be post-8, so overdue and coming up to 42 weeks. It could be related to conditions like gestational diabetes or pre-eclampsia. There's actually quite a long list of reasons why we might recommend an induction. And even though that list is long, the underlying principle of why it's being recommended will always be the same. It's that your doctor thinks it's safer for you to deliver your baby rather than staying pregnant. There are also lots of different ways that your induction process can take place, and there are always slight variations from hospital to hospital, and even in the same place you might find that there are slight differences in the way that certain people do things. So it all depends on where you're having your baby and at that time that happens for you. There are mechanical forms of induction where we use things that don't have chemicals in to try and open up the cervix, and that's recommended usually for people who've had caesarean births before. There's more information on that in our vaginal birth after caesarean video. So, induction of labour, what are we trying to do? We're trying to copy and mimic what your body would naturally do without any intervention, how your body would naturally go through those processes. That's what we're trying to do, and we're trying to get you into labour, and we're aiming for a vaginal delivery. There are stages for an induction. So that first stage, we're copying again what your cervix would normally do. So normally, this early phase could take many days in the community, and what your cervix will be doing, so this is your cervix, that's the neck of the womb, the opening to your womb. It will start off being quite closed, but over the course of many days, what will happen is it will open a little bit, and it will soften a little bit, it will shorten a little bit, and instead of being tucked away right at the back of the vagina, it might come more towards the front. And those are all the same changes that we are trying to bring on. And the way that we commonly do that is we give something called a pessary. So if this is your cervix, a pessary is a thick ribbon that's soaked in something called prostaglandin. And so the ribbon will go right at the back and be tucked up right behind the cervix here. You might not have heard of prostaglandins before, but there are lots of different types of them, and they're a chemical that, for example, they play a big role in, say, having period cramps. And when people tell you to have sex or eat spicy food or eat dates, even though there isn't masses of evidence behind those recommendations, the kind of thinking behind them is that they might stimulate some prostaglandin release. So instead of maybe hoping that something stimulates prostaglandin release, what we're doing with an induction is giving you some prostaglandins. So this pessary will sit here for up to 24 hours. Some hospitals might recommend only one, some might recommend two, for example. Maximum 24 hours, but baby will be monitored at regular intervals, and we can always remove it earlier if we need to. If for any reason you are, say, for example, contracting quite a lot, or we're worried about how baby's responding to those contractions, we'll firstly remove the pessary, which is very easy to do, and if we need to, we can give you a medication that relaxes the womb and giving both you and your baby a bit of a rest. So after the pessary, if your cervix is not quite open yet, which is quite common if you've not had a vaginal birth before, the next step is to give you something, also a prostaglandin, but a different type. And this one goes in either as a tablet or a gel, again right at the back here. And this one lasts up to 6 hours. Some people break the waters by themselves, but a lot of people don't. So when we're moving on to that next stage now, your cervix is like this to this, we want to be able to break your waters. In order for us to break your waters, we need a few things to kind of line up. We need there to be a room just for you, we need there to be a midwife, and we need it to be safe for us to proceed to that next step. So that means there can't be lots of emergencies going on, there can't be lots of possible emergencies happening, because we need to make sure there is enough staffing and enough medical team members available to help you should we need to. So if we imagine that baby is in a balloon, and all around baby is the amniotic fluid, and the balloon are the membranes, the waters is what we say. Your midwife usually, when you're in that room, will examine you vaginally and put their finger through the cervix, and will use something to break the waters on the other side. After we break your waters, we wait a couple of hours, a few hours, to see if you're contracting. Sometimes people manage to get themselves into labour with just that, and usually those are people who've had vaginal births before. If you're not contracting 3 to 4 times in 10 minutes after that, that's when we recommend the hormone drip. So the hormone drip is a man-made version of oxytocin. That is a hormone that's very important in labour. And in all these last few weeks in your pregnancy, you've had all these little receptors that have come up in your womb and they're ready for oxytocin, whether that's oxytocin you produce yourself or the man-made version, syntocinon. We've got a lot of control over this hormone drip, so we don't just start it off straight away and all of a sudden you feel lots of pain. We actually build it up gradually. It also wears off quickly. And baby will always be monitored when you're on the hormone drip. For any reason we're worried, we can just reduce it or turn it off completely. The contractions from the hormone drip tend to be more painful than if you were contracting by yourself. So, not everyone who has oxytocin, the drip, needs to have an epidural, but lots of people do ask for an epidural. And we have a team of anaesthetic doctors who will be there on the delivery suite, whose job is to make sure you are comfortable in labour. So what are we trying to do with the hormone drip? We're trying to give you and get you to have 3 to 4 contractions within 10 minutes. And why do we want those contractions? We want your womb to contract, to bring baby's head down. We want that cervix to dilate. So you've gone from this to this. Now we want the hormone drip to get you to 10 centimetres and to keep giving you those contractions when you're 10 centimetres, so when you're fully dilated, to help deliver baby vaginally.